Much. With that, we will move on to our next talk, which will be elevation-based tomography with the Pentacam, expanding indications. This will be given by Professor Amit Gupta from the Advanced Eye Center, PGI Chandigarh.
Well, thank you. And, as we know that the Pentacam works on the principle of Scheimpflug, photography, and it's a tomographer and leads to a 3D reconstruction of the anterior chamber. And there's quite a big drop down which comes once we have to see what data of the patient we want to analyze. So if we go first to the overview map of the patient, in one glance it gives us a lot of information of the curvature of the cornea, anterior chamber analyzer, keratometric values. It gives us a 3D model of the anterior chamber and also the Scheimpflug imaging of the eye. And one rarely used map is a MAPS chamber, which is basically, it concerns the anterior chamber depth, helps us to plan ICL surgeries, identify patients at risk of glaucoma, follow them up after surgery, and so many other applications. If we come to Scheimpflug images, at one glance, it shows us the anterior posterior curvature and the relations. For example, in this photograph on the left, we can see it's a patient of keratoconus. It's thin in the center, and we look at the periphery, the ratio is totally disturbed. Also, this Scheimpflug images, this is a patient of femtokeratoplasty, and we can see the mushroom-shaped border of the graft on Scheimpflug imaging. Also, it can be used to measure the ICL vault in these patients. It does have a nuclear staging and a 3D cataract analysis, which can be done using the Scheimpflug imaging. Also, something which is not used that often as it should be is fast screening report. And this is what it looks like. The two bell curves, one is red and one is green. And it shows various values. Basically, the red bell curve is that of the pathologic population, and the green one is of the healthy population. The black line indicates where the patient's data compares. So just at a quick glance, we can see the anterior chamber profile, we can see the corneal thickness profile, we can see the corneal surface, the corneal clarity, as well as the cataract grading in this patient. And of course, as I said, the nuclear staging module, it helps us to customize phacoparameters before the start of surgery. If we come to further colored maps, which are there in the first section of the drop down, it gives us the basic topography info of the patient. So this is a typical 4 maps refractive, and it gives a sagittal curvature of the front. It gives us a map of the corneal thickness. It gives us some front and back elevation maps of the cornea. So this is usually the first map which we start off with. And just to go over some values which are significant, if the elevation on the anterior surface is more than 15 microns, we regard it as a significant at risk for ectasia. And if the elevation of the back surface is more than 20 microns, it is also regarded as significant. And preferably the difference between the two should be less than 5 microns. And this is something known as the Belen-Ambrosia enhanced ectasia display. And if we look at this display, it also gives us a value called the D value, which is a composite of the deviation of various parameters of elevation, which is away from the normal. So from this comes the concept of the best fit sphere, against which the values are given. So a sphere, usually it is 8 millimeters of the cornea, and it assumes the cornea to be equally curved in all directions, which is not accurate in astigmatic or irregular eyes. And it may be useful for detecting gross abnormalities, but the best fit toric ellipsoid is, it takes into account both the asphericity and the toricity of the patient. So it is highly accurate in early cases of keratoconus or very subtle changes we want to see in post-surgical corneas. So this is the standard reference, and it is particularly relevant when we want to study the posterior elevation in detail. So why it matters is that the choice of the reference shape directly influences the elevation values, and a protrusion may appear subtle on the best fit sphere, but clearly on the best fit toric ellipsoid. So, and this is especially useful for early keratoconus. So in one case, a 27-year-old female wanted refractive surgery, stable refraction, and manifest refraction of minus 4.25. And we can see, look at this map, and shows a slightly steeper cornea, a reasonable corneal pachymetry, and same for the other eye. And if we look at the Belen-Ambrosio display, it shows the values in red as an abnormal values, and also a borderline D value, similarly for the other eye. Now, in this case, would you do refractive surgery on this candidate or not? So what I wanted to bring out was that if we look at the white to white of this patient is 10.5. So this is, on this map is, we should not just read it with our eyes closed and say this is red and not do it. So a small white to white or even a large white to white more than 12.5 can alter not only the bad D maps, it can alter the pachymetric maps, it can alter the artmax values, and this can lead to false positives or borderline scores which are confusing and are sometimes crucial for both the refractive and keratoconus diagnosis. Thickness progression map is a good map. It just tells us the standard deviations within which the pachymetric thinning progression or thickening profile of the cornea is normal or abnormal. Another clinical situation, a patient or high myope, -5 with -1.5 cylinder and -6 with -2.5 cylinder. And if we look at these maps of these patients, we can see that the cornea is on the thinner side, and patient wanted a refractive surgery. This is the other eye. Again, shows a reasonable profile with a thin pachymetry. And if we see this, so this is a thin cornea with a suspicious D value, and we calculated the residual stromal bed thickness was also less along with the PTA. And so what next for this patient is, since the patient had a reasonable anterior chamber depth, we planned this patient for an ICL. In ectatic corneal disorders, important to understand definitions, form first keratoconus and keratoconus suspect and subclinical. Form first when the fellow eye of a clinical manifest keratoconus eye. There is no clinical finding except for certain topographical changes, and a suspect when a localized area of abnormal inferior but maybe central or really superior area is present. And in a subclinical keratoconus, a fellow eye of a clinical manifest keratoconus with following features, that is no clinical finding and some amount of asymmetry. So this 28-year-old male, refractive error, which is minor with a little bit of a cylinder thrown in, and we can see the values of the patient. It appears a little reasonably okay except for the elevation on the back surface, and we see the Belen-Ambrosio map of this other eye of the patient. And similarly, if we see the left eye of the patient, we see the findings which are just borderline values and a little bit of anterior elevation and a D value of 2.46. So this is a 28-year-old female with a anterior and posterior elevation and a bad map abnormality. And so this is a keratoconus suspect, and we should observe these patients at reasonable intervals with Pentacam and follow them up. Also, another patient, 24-year-old male, right eye not accepting and left eye with a bit of a cylinder, 0.75 cylinder, so overt keratoconus in one eye. And if we look at the other eye of the patient, there is an inferior steepening of the patient in the patient's eye. And so right advanced, left form first keratoconus, plan was right DALK and left eye 6-monthly observation in this patient. So we do have these maps which show us at a glance whether the patient is progressing or not. And in every patient of keratoconus or keratoconus suspect, we should take a look at this map. There are green flags and red flags, and so basically in established disease, if the follow-up reading crosses the red flag, it's significant, any one, or if there are two parameters which cross the 80% dotted line. And similarly, in very early disease, even if it crosses the green gate, it is considered to be significant in these patients. So this is a patient's map, and it shows, or the pink line shows that the patient has progressed from the last visit, and this should be considered as a progression in these patients, and probably patient should be taken up for cross-linking instead of just observing. Another use of the topometric map is to plan the intact surgery and decide on which axis you want to the incision and how to place the intacts in these patients. And this is a pachymetric map, and we use it so often when to plan DALC or to plan INTAX or femtokeratoplasty and so many other procedures, even the depth of the flap in SMILE and LASIK can be planned by using the pachymetric map. Going to the further down on the drop down, it's very useful is the comparative display. So for example, a patient who's post cross-linking, and we want to see has the patient done well after cross-linking. So it subtracts the data from the two readings and gives us so in this case, there is hardly any change on the bottom right corner. So it indicates that pentacam is stable in this patient. Now, in some cataract surgery situations, this is a patient of keratoconus. Now, some publications have shown that the use of total corneal refractive power when we are doing biometry is critical to having a good outcome and avoiding hyperopia in these patients. So, if you go to the cataract pre-op map, the middle map shows us the total corneal refractive power. And it has been by Watson et al., they've said they use the TCRP at the apex. So in this case, it is like 52.8 at 3 millimeters, and this patient did quite well after surgery. So again, a patient who's operated radial keratotomy. So these are distorted corneas, and they have a lot of flattening in the center, and also in irregular corneas, we can see in the 4-map refractive. And so in these cases, also we can use the Pentacam Holiday report. And so it shows us the aberrations of the cornea. It can tell us the chord mu to show the centration, that is whether a good candidate or a bad candidate for a premium IOL. Also the monofocal eye. So in this case, we planned a monofocal IOL with the negative spherical aberrations. And so this is one of the ways that we can use the Pentacam in complicated cataract surgery. Of course, one very important map is the EKR detailed report. So what it does is it shows the distribution of K readings in these patients, like a patient of post-refractive surgery or post-radial keratotomy, by bringing in a corrective factor compared to the normal. And this is then, if there are zones which are like 2, 3 or 4.5 millimeter zones. So this is a weighted mean, which is then given by the Pentacam. So weighted means that values of some parts, like the central part of the cornea, are given more weightage than values in the periphery. So this gives, it's not a mean or an average, so that gives a better value on which to plan the surgery. In this case, the patient was -1 post-operatively. We use the EKR at 3 millimeters in this patient. So summing up, the Pentacam is a very useful tool for not only screening for refractive surgery and planning laser vision correction or phakic IOLs, also to diagnose keratoconus and follow up and manage, for example, cross-linking. So important to see whether it's worked or not and how the patients are doing. And also, you plan INTAX or DALC or femtokeratoplasty or even a keratoplasty you have to decide the diameter of the patient in the graft in a keratoconic eye. So you can use that. And I even use it to follow some patient of herpetic keratitis. For example, we want to see the edema, and we have the pachymetric map, and we can follow up whether how well the patient is doing, or a Fuchs endothelial corneal dystrophy. The pachymetric map is a great map to see. Also, it can help us to see post-PK patients, help in selective suture removal, help in toric IOL planning, lens density, and the IOL power calculation, of course, after cataract surgery, contact lens fitting. So the list is endless. I think it's an important tool. This is the team, cataract refractive in AEC PGI, who I would like to thank, and all of them contribute so much to whatever we say or do here. Thank you so much.
Thank you, Professor Amit. I think that was a very, very comprehensive coverage of the uses of the Pentacam. Any comments from the panel or any questions from the audience?
Yeah, it was a great talk, sir. I would just like to ask, at which map would you like to look at when you plan a toric IOL particularly?
The aim of us when it comes to using a toric IOL is, one, to see whether the surface is regular or it has an irregular astigmatism, which is fairly clear when it comes to just if you see a 4-map refractive, it is all right. we can go to the TCRP maps or to TrueNet Power maps. I don't use that usually. I rely on the IOL master. I do take a look at the Pentacam, see that the but I don't use those readings of Pentacam to plan my toric IOL surgery. I don't do that.